that up and running. Okay, I'm printing out the item that you need.
Okay.
And I'll go over it with you a little bit later.
Okay. Do you think maybe they're waiting?
I think they're probably waiting.
Do you want me to open the door?
Yeah, if you don't mind.
Oh, we're in the side already. Did we? I was.
Good morning. Happy Monday. It is the last Monday.
The applications go out today.
Oh, yay.
Thank you.
And we'll go over it a
Okay.
little bit. All right.
It's like that on
Last Monday of class.
I know.
I know, I'm not sure. It's Monday, so.
Who knows who'll show up?
Yeah.
Miss Patty, I have a question.
Yes.
So we give this nursing basics book back to you,
Mhm.
right? But everything we really need to still know for the
Is
exam
in the white
your
book.
Okay.
Yeah.
Okay.
and that's the one you get to keep.
Right. Oh, nice. So I see.
Okay, let's get started here. Oh, yay. Look, looks like our technology is working. All right, sound check. That's good. That's a happy Monday when everything works. So yes, to answer your question, on Wednesday, you guys will bring. Okay, Caitlin, no problem. You guys will bring back your yellow books and turn them in, and you get to keep the white book, and that's the one that has all the information you need. Yellow book is just kind of background information, things that you need to know, but there's nothing in there that you're really going to refer back to, like ever. As long as you kept up with your reading, you'll be fine.
I think I'll have to read the book one more time tomorrow.
All right, so there's only a couple of you here. It must be Monday. Okay. So Rebecca, can I get 2 through 9 from you if you have them?
Yes.
The answers. So it'd be page 133 on.
You want the answers?
I need your score, like how many you missed.
Okay, gotcha. On chapter 2, I missed 2.
Okay.
Yeah, and then chapter 3, I got a 90.
Okay.
Chapter 4, I didn't do.
Okay.
I didn't do. Oh my goodness, I'm so behind. I didn't do 4. I still have to do 4, 5, and then the rest.
Okay. All right. No problem. All right. Let's see here. Allison.
Chapter 8, I got 100. And chapter 9, I got 1 wrong.
Very good. Kristen.
I got 100 on both.
Very good. And hold on. I know it. I know it. I know it. Give me a minute. I know this. I want to say Janice D. Nope.
No.
All right. Give me a hint. Keely. There you go. Okay. Keely, how did you do? Thank you. Do you happen to have 7 for me as well? Thank you. Okay. Did you get your card?
Yes, I did.
Good. I had some trouble.
Yeah, you realize I got the yesterday. I was like, okay.
Yeah, I had a little bit. Hi, good morning. I had a little bit of trouble getting first class.
But I got it.
Downloaded it.
Downloaded it this morning.
Good. Very good. Okay. As long as you got it, I'm good.
Yeah.
So my system worked. Yay. Okay. Any questions on what you went over, what you learned, what you read? Final questions on the class last week? Can't believe it's almost over. Goes fast.
Mm-hmm.
How did you do on chapter 8 and 9?
Good. I got 100 on both.
And remind me.
Chapter 7,
Okay, what was your name?
Mariah.
Mariah, thank you. So let me find you here. Okay, 100 on both. And chapter 7?
100.
Thank you. All right. So we have 3 skills to learn today. That's it. Just 3 skills. 2 of them are repeats of skills we've already learned. We're going to learn another range of motion. You guys remember the range of motions that we learned? Shoulder. And then we learned elbow and wrist. You guys remember that?
Mm-hmm.
Well, now we're going to learn hip, knee, and ankle. That'll be the next one. It'll take 3 minutes. Literally. It's a very, very, very quick skill. Good morning. So we'll do that one first and get that one out of the way because that's the easiest skill for today. We're also going to learn catheter care. And if you remember, on Wednesday, we learned pericare. Well, catheter care is pericare with an extra step. We're just going to clean the tubing. So instead of cleaning the backside, because their butt's not laying on a wet pad, right? Because the catheter is collecting all the urine. So we don't need to clean the backside. We're going to clean the tube instead. Okay. So Pericare plus tube is catheter care. Pericare plus backside is Pericare. Good. But you already know most of that skill. Not much there to learn. And then we're going to learn emptying the drainage bag. And this is every catheter is attached to a bag. We have to learn how to empty it and measure that content and then record it. It is a documentation skill. So I'll show you that as well. They're not long skills. Good morning. They're not long skills, guys. It does take me a little bit of time to teach them because we have to go over what a catheter is. How does it work? What are the things that we want to look for? What are the risks associated with catheters? So there's some stuff that we have to go over, but the skill itself is not too bad. Okay. All right. So one class left, guys. Did you register for the test? This is going to be up there every single class now. Did you register? If you didn't, you need to. Be mindful. The longer you wait, the harder it gets. So you guys are almost done. You're getting ready for that test. You're probably stressing a little bit. Come to my game show. The next one will be on, it'll be 3 weeks. I think 3 weeks, 2 weeks. The first Tuesday of September. So the first Tuesday of September at 11 a.m. I'll have another live game show. And you can win prizes too. All right, so let's get to page 57. Do you guys remember why we are doing range of motion?
To make sure you're looking at moving their joints, but then to make sure that everything looks okay.
Okay, yeah, it gives us an opportunity to make sure that there's no problems. Are we doing range of motion to make things better? To maintain. So what if we're doing range of motion and our patient says, ow? Okay, so the next one would go below the ow. Mm-hmm. Who are you going to tell about the ow? The nurse, right? We're going to report it. So we're not going to say things like, oh, you'll be fine. You know, progress hurts. We don't want to do any of that. Please remember that CNAs are one of the few healthcare workers that don't hurt patients. If we hurt somebody, we took a wrong turn somewhere. Because most people in healthcare hurt the patient in some way, and we don't want to do that. Not our role. So if we're doing exercises to maintain what we have, that means that we have to know what exercises we're doing, what body part we're exercising. It is on, okay. What body part we're exercising and how many repetitions to do, right? So where would we get that information? The care plan. So the care plan at the top of the page tells us to provide the following range of motion exercise to the resident's right, hip, knee, and ankle. Now this one's kind of neat because it's a 2-for-1 exercise. Everything else we've done, we exercise the elbow and the wrist separately, right? We exercise the shoulder separately. But when we exercise the hip and the knee, we're going to do these two joints together. And there's a very specific reason why. We have, oh, I think he put my book away, didn't he? He did. He's too efficient. All right. So if you look at the human body, and I wish I had the big, maybe I have it back here. Let me see if I can get the big book and let me show you something, because I think visuals always help. Yeah, he must have taken it next door. Okay, so let me explain this. You have a brain. Your brain is attached to a spinal cord that runs down your back. That spinal cord at the base of it branches off into two, and those run down your legs. Good? Right? Because we're hardwired beings, we're not wireless. So if I stub my toe, there's a physical wire, a nerve, that signal has to travel up to get to my brain to say, hey, brain, we stubbed our toe. So we have these nerves running down the back of our legs. Not a lot of slack here. So if we try to lift the leg up, right? So the back is flat on the bed, and we lift the leg up and keep it straight, that's going to pull that nerve really tight. Does that make sense? So as we age, things change in our body. And one of the things that changes is the amount of slack that nerve has. When you're young, you're still very bendy. That doesn't last forever. Enjoy it while you got it. Okay, you're very bendy. As you age, you get less flexible. And part of that is you know, your nerves have less slack to them. So if we've got an older individual and we try to lift their leg, straight leg off the bed and up, that's going to put a lot of pressure on that nerve up into the back. And a lot of our patients have sciatica, which is an inflammation of that nerve where it branches off. We don't want to do that. We don't want to hurt our patients. So instead of raising the leg straight, we're going to bend it at the knee. When we do that, there's more slack in the line. Okay. So when we're doing range of motion of the hip and knee, we're going to do them together. Instead of raising the leg off of the bed like this, we're going to raise the leg off of the bed like this. And if you look, let me go sideways here. If you look, my knee is bent and so is my hip. So it bends both of them at the same time. Okay. So our exercises that we do or that we can do, flexion extension is up, down. Abduction, adduction is away. You're kind of a side to side, away and back. Rotation is around. So we know these three exercises. What we need to know is which ones are we doing on this joint on this patient. And that's what our care plan is there to tell us. So our care plan told us that we are going to do the right hip, knee, and ankle, that we're going to do flexion extension, and we're going to do 3 repetitions. Okay. So this is what I was referring to. When you do a straight leg raise and you don't bend that knee, that puts a lot of pressure on this nerve. When you bend the knee, it's going to bend the hip and the knee at the same time. So we count this as a 2-for-1 exercise. So when your patient's laying in bed, it kind of looks like they're climbing stairs, right? We bring the knee up and toward the chest and bend them back down to the bed. So their leg is bent like they're climbing stairs. Okay. Now, when we get to the ankle, and that's the only exercise they're told to do is flexion extension. So knee to the chest 3 times. And then we get down to the ankle and we're going to do flexion extension on the ankle. So we're going to bend it forward and back 3 times. Super easy. But we don't want that heel to scrape against the sheets while we're bending it forward and back. Right? That heel is going to scrape. And that can damage the skin. So we want to lift the ankle off the bed a little bit. So when we flex the foot forward and back to the head, that heel isn't scraping. That's a whole skill. The opening, knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA today. I'm going to do some exercises. Is that okay? Yes. Awesome. We pull the curtain, wash my hands. I'll be right back. When you come back, you're going to lift the leg up, bend the knee to the chest, back down to the bed 3 times. You're going to lift the leg at the ankle, support it underneath, bend the foot forward and back 3 times. And then we're going to do our closing. Thank you very much, Miss Jones. Is there anything else I can get for you? Are you comfortable? Here's your call light. Environment's clean. Open curtain. Wash hands. Skill is done. Good. So super quick. If you look at the bottom of the page, you'll see that somebody with your level of experience should be able to complete this skill in 4 minutes or less. Not much time, but it's not much on the skill either. Okay, these are the quickest skills that we do. Real quick, this is a question I get asked a lot in this class is, do I have to say everything you say to the patient? And the answer is, well, kinda. Remember that your patient doesn't know what's happening. They don't know what you're doing. They're not a CNA. They don't know your task. And being in a medical facility is super scary for our patients. If they don't know what's coming next, they're probably going to stiffen up. They're going to be a little resistant. So the more information you give your patient, the better, more compliant they'll be, the better they'll trust you, because they don't feel like anything is being forced on them. So the answer to that question is, yeah, you probably should. You probably should talk it out, but you don't have to say everything I say the way I say it. Although there's lots of people that do. Have you ever watched a movie so often you learn the lines? Right? A lot of people get through the test that way. They just watch my movies on repeat.
How many students go in there for testing and go, "Hi, Miss Jones," and they all know that?
Yeah, they're
came
all
from
from
you.
me. Yep, yep, yep. Happens more than you would think. Happens more than you would think. Yeah. In fact, the evaluators, when you go in there and you start doing your skills, they'll know where you came from. Yeah. Just because you're prepared in a very specific way. But it's funny because when you're sitting in that waiting room, because remember, I have a national presence, right? So most of the people that are sitting in the waiting room have seen my videos, either in their school, because most schools use my videos, the ones that I show you in class. So they either saw me in school or they saw me because they're, at home preparing and looking up videos and stuff. So almost everybody in that waiting room knows me in some way, has seen me somewhere. When you say that you actually took the class with Miss Patty, you guys get like celebrity status. It's funny. Students come back and tell me that all the time. So it's be prepared for that. It's kind of fun. This skill is not hard, guys, as long as you know the recipe. Follow the recipe.
So this is talking about flexion and extension, right?
Right, flexion, extension.
Extension. Okay. So, but what if it's like, oh, instead we're doing the rotation one?
Okay.
Are you going to have that option? Is it going to be this on the exam, or is it going to be maybe a different type of movement?
Okay. So I'm going to answer that in 2 ways. So for the exam, the actual exam, this is your care plan.
Okay.
There's no variation.
Okay.
This is it. And that's because testing has to be specific, but it also has to be universal, consistent.
Yeah.
So if somebody's testing in Miami, somebody's testing in Tallahassee, and somebody's testing in Jacksonville, and they all get range of motion, hip, knee, and ankle, it all has to be the same care plan so that it's consistent for testing. So this is it. This is the care plan you will get.
Right. Okay.
Now, in a clinical setting, not all care plans are going to be like this because they're based on the patient.
Right.
So if you remember for shoulder, range of motion shoulder, you guys remember that a million years ago, right? So range of motion shoulder, we did flexion extension. And remember, flexion extension brought the hand up in front of us, like we're asking a question, and then back down. Abduction, adduction brought it out to the side. Hand ends up in the same place, but it's a different movement, right? You guys remember that? Same thing with the legs, right? So flexion extension for the shoulder was up. For the leg would be up, except we're not doing straight legs. So we're going to bend that knee at the same time, and then we're going to bring it back down. So that means abduction, adduction. If abduction, adduction of the arm is side to side for the leg, it'll be side to side, right? So like a snow angel. Rotation, though, is not a pitcher wind up. So, and we kind of talked about this a little bit in class. So for rotation, a lot of people think, okay, rotation of the shoulder would look something like this, right? A pitcher wind up, right? Either forwards or backwards, but it's actually not. It's if you hold your hand out, palm up, and turn it upside down and feel what that does inside your shoulder. That's the rotation we're looking for. Same thing with the leg. So this looks like rolling cookie dough. This would be rolling or the twist, right? That's actually rotation on the hip.
If the care plan says to do this, but let's say it didn't include the knee, would you still bend at the knee for the hip?
You'd want further information from your nurse.
Oh, okay.
I can't answer that because I don't know what's going on with that patient. If they just had a knee replacement done, then they may not want us to bend that knee.
Oh, okay. So there's a chance that you may have to like pinch that nerve a little bit.
Possibly, but again, CNAs don't
Hurt.
produce pain.
Yeah.
So in that situation, it would be better for the physical therapist to do it, and PT is usually involved with that. So you would want very specific information. Remember, we're just trying to maintain what the patient has. So chances are you would not be doing range of motion on a knee that just had knee replacement. You'd be doing it on the other side because this patient isn't going out and walking a mile a day with a knee replacement, brand new. So we're just trying to prevent blood clots from happening. So you would be on the other side. PT would take care of the affected side. So again, you want to go by that care plan. There's a million reasons why we wouldn't want to bend a knee. You know, I mean, I could come up with a ton of scenarios, but that doesn't, you know, it's all patient specific is what I'm saying. Okay. If you have a concern, bring it up to the nurse. And here's the thing, guys, and I need you to understand this without being disparaging. Your nurses are busy. I mean, they are seriously busy. You're busy. Everybody's busy. We are being asked to do the work of 2 or 3 people at less than the pay of one. You know, I mean, it's everybody out there is super overwhelmed. It's just the state of our current economy. But the problem is that if your nurses are busy, there's a chance that they may miss something here and there. It's possible, especially when their phone is ringing off the hook because the lab is calling with a critical lab value. And then they've got to stop and get a hold of the doctor. And then an admission comes in and they got to get back to this care plan an hour and a half later. And they may forget to write rotation on there. You know, they've got so much. It's not like they can lock themselves in a room and write out a whole care plan nice, you know, with no interrupt. It doesn't work like that. Not in a clinical setting. So mistakes are going to happen. Things are going to get missed. Things aren't going to be on the care plan that, you know, that you need. Form a working relationship with your nurses. Don't say, oh, that stupid nurse, she didn't put this on the care plan and, you know, she's just lazy. That there are people that write really, really, really good care plans. There's people that write, nah, not so great care plans, right? If you've ever read a book, it's kind of the same thing. Some authors are awesome. Some are not so great. But if we develop a good working relationship with our nurses and say, hey, this care plan isn't clear, you know, am I supposed to be doing a straight leg raise here or am I supposed to be bending the knee too? You know, can you give me some feedback here? And she may say, oh my gosh, I didn't put the knee in there. Oops. Yeah, do the knee. We don't want to hurt this patient. So again, it should never be you versus the nurse. If you find a mistake on the care plan or an omission on the care plan, just go to them and ask. That's how the patient wins. Okay, good. Does that make sense? Okay.
Oh, someone sent a message.
Oh, thank you. Thanks, Caitlin. Good morning, Miss Patty. I passed my CNA exam last week just by watching you. Thank you so. Congratulations, Angie. Great job. We are super proud of you. All right. So any questions on this care plan? Thank you. I'm talking about putting a monitor back there just so I can see, because it's hard when it's behind me. All right. So any questions on this care plan? No? All right, let me get my camera set up. So give me just a minute, and then I'm going to show you this live in person here. Because the other two skills, I have to show you the videos because I have really good close-ups. And you're going to need that to really kind of understand how to do the skills. So give me just a second. Alana, take your time. No worries. I'll put your scores down. Thank you very much. Welcome, Savannah. I'm glad you made it to the live. And hey, Jennifer. So happy that you joined us. Jennifer is one of my core crew. She joins pretty much every week on our weekly live, and I'll be resuming those next week. I'm super excited because I miss going live every Thursday. I miss my peeps. So Jennifer, welcome. All right, let's see here. Let me get set up. I ordered my new one. Okay, we're good. All right, I need a volunteer. Somebody to come lay down in this bed. And I will show you range of motion, hip, knee, and ankle. Anybody? I know we always have a designated patient. I don't know why. We always have a designated patient. All right, just to remind you guys here, go ahead and lay down. You're fine. We always want to support the extremity. We always want to lift from below, never above. We're not the claw machine at Walmart. We want to move slowly and smoothly, and we're going to return all the way to the start position. Flexion, extension is up, down. Abduction, adduction is side to side. Rotation is around. We want to ask about pain or comfort as we do this. These are our test-specific things. Now, this patient right here, fully clothed, holding onto all of her body fluids like a champ. Good job. She didn't have any personal skin that I am going to come into contact with while doing this skill. Do I need gloves? No. If she had a horrible shingles rash somewhere that I might come into contact with, would I need gloves? So are gloves based on the skill or are they based on the patient? Always the patient. So it doesn't matter what skill we're doing. We always evaluate if we need gloves, because we may not need gloves for her, but that lady over there, same skill, we need gloves. So at the beginning, we always think about our glove rules. Good? All right, here we go. I am going to simulate hand washing for the sake of time today. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Fantastic. I need to do some exercises on your right leg. Is that okay? I'm going to close your curtain. Let me go wash my hands, get my supplies. I'll be right back. I have clean hands. That's all you have to do for the test. Okay, I'm going to do all the work. Your job is to let me know if there's any pain or discomfort as we do this, okay? First thing I'm going to do is lift your leg off the bed, bend your knee to your chest, and back down to the bed. We're going to do this 3 times. I'll do the work, okay? Now, you can raise the bed up to a comfortable working height if you want to, no problem. Remember, this is less than a 4-minute skill. I'm comfortable bending for that amount of time. So I don't raise the bed. Because if you raise a bed, what do you have to remember to do? Yeah, and at the end of the skill, you may forget because you're kind of rolling. You're trying to, move along. All right, so I'm going to bend your knee up to your chest and back down to the bed. So I'm going to support under the knee and under the heel, and we're going to go up and all the way back down. Good? Any pain? Up. All the way back down. Still good? One more. Up. All the way back down. Great job. Okay, now I'm going to move on to the ankle. I'm going to lift your foot off the bed just a little bit. Bend your foot forward like you're stepping on the gas pedal, and then back towards your head. You'll feel a little gentle stretch. So I'm going to lift, bend forward and back. That's one. Forward and back. Still okay? And forward and back. That's three. Thank you very much. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? All right, let me find your call light. It's probably buried here somewhere. There it is. Here's your call light. If you need anything at all, just press that red button. Thank you. I'm going to open the curtain, wash my hands. I probably would go back and review that care plan one more time. Make sure I did the right body part, the right exercises, the right repetitions. And then once I'm happy with it, I'll tell that evaluator my skill is done. Once I say that, I can make no more corrections. So don't be too fast. Think about it a little bit. Thank you. All right. Any questions on that? Any questions on that? All right. Let's move on. Page 114. Oh, yeah, you might need those. All right, so page 114 gives us our care plan at the top of the page. Care plan says provide catheter care with soap and water to a female resident with an indwelling urinary catheter. Clean the catheter tubing and peri area only. Do you guys remember as we've gone through the class, we found out that most things have two names in medicine. It's not just one. Why limit yourself to one when you can have two or three even? Well, that's what we're going to deal with again with this. An indwelling catheter means we put it in and it's going to stay in for a little while. Could be 30 minutes, could be 3 days, it could be up to 30 days. An indwelling catheter has to be changed every 30 days by the nurse, but we're leaving it in some way, okay? So an indwelling catheter is also called a Foley catheter. You'll hear both. An indwelling catheter is also called a Foley catheter, but they're designed to be left in. We're going to learn a little bit more about catheters in just a minute, but let's review peri care. So if you remember peri care that we learned last Wednesday, we changed the chucks out because remember the patient was on wet chucks. We used the leaves method and cleaned the peri area from top to bottom, never going back up, down the middle, side, skin fold. Whatever we washed, we
Rinse.
And whatever we rinsed, we okay. And then we turned our patient over and we cleaned the back side, up the center crease, one cheek, the other cheek, up the center crease. Whatever we wash, we
Rinse.
whatever we rinse, we dry. And then we change that chucks out again, so we have a clean bottom on a clean chucks. You guys remember that? Okay. This is going to be very, very similar to that, except that we don't have to clean the back side. Instead, we're going to clean the tubing, the catheter tubing. We're also not going to change the chucks under the patient at the end either, Because remember, with pericare, we have to have something there to absorb urine. That's what the chucks is for. But when we have a catheter, we have a catheter to absorb the urine. I mean, that directs the urine away from the body. So if we put a chucks under that patient, chucks are plastic lined. It's going to hold in body heat. It's going to make the patient sweat. And we have warm, dark, moist. Is that a good environment? So at the end of this skill, we're going to take the chucks away. We never use a chucks under the patient unless we have a need for it. Okay. Doesn't matter whether it's the plastic disposable chucks or a fabric bed pad that's washable. Same process, because they are waterproof. It's ultimately going to hold body heat in and make us sweat.
I had a question, but I just looked at. I was thinking, how are we going to perform this on a student? But it says mannequin. So
Yeah, we're going to get there.
Okay.
Yep.
Okay.
Yeah, this is not a live patient still. But yes, we will get there. All right. So this is what a catheter looks like, roughly, artist drawing. You have a hollow tube. Think of it like a straw. That's really what it is. It's closed in at the tip here just to make it easier to insert, because an open straw would be really kind of hard to get in there. We want something that's soft and closed in. And our opening, instead of being at the top like a straw, is on the side. So once we get this into the bladder, the urine's going to go down that hole, down the tubing, and it's going to come out this hole, which didn't help us a bit. So we want to attach this to some sort of a collection device, a bag. So when we talk about catheters, there's actually two pieces to this puzzle. You have the catheter, but then you always have whatever the catheter is attached to collect the urine. Two pieces. Right now, we're just going to focus on the catheter itself. As CNAs, excuse me, sorry. As CNAs, our job is to clean the catheter. Our job is to make sure the skin around the catheter remains clean and make sure that the catheter tubing doesn't get kinked or pinched or otherwise prevent the urine from flowing through it. Make sense? Good. We also want to inspect the bag and tubing to make sure it's not near the floor and it's not kinked as well. Have you guys ever really had to pee? I mean, really had to pee, like you're doing the dance because you got to go so bad, right? Really have to pee. All right. Now, imagine that you really have to pee and you physically cannot. You can't. You try and nothing's coming out, right? That's not going to go away. It's actually going to get worse because we need, you're out of room, bladder's full. If we can't empty that bladder, it's a real problem. Well, if we have a kinked catheter, the urine's not going to come out. And that bladder is going to fill and fill and fill and fill and fill. And eventually it's going to back up into the ureters and into the kidneys. Is that a good thing? Absolutely not. So part of our job is to make sure that this isn't kinked. If you have a patient with a catheter and they're like, oh my gosh, I feel like I'm going to explode. I have really got to pee. You need to look because that urine may not be coming out. And if it's not coming out, that means it's still in. And that's a problem. Good? Okay. As nurses put catheters in and they take them out.
So we don't do any of that.
We don't put catheters in. We don't take them out. You can be trained to do so. It falls under delegation. A nurse can train you to do additional tasks, that you can be trained to do this in some places. Now, some state laws address this. Florida doesn't. Florida says whatever the nurse wants to train you in, as long as you have the ability and the skill level, the nurse retains the liability. As a nurse, I am probably not going to train you to do these tasks if I'm liable for them. There's just some things I'm not willing to give up control over. This is one of them, because the risk for injury, if you're not doing it right, pretty high. So let's talk about the whole system here, how this whole system works. So at the, let's start down here at the bag. So we have this drainage bag that's going to collect the urine. Drainage bag has markings on it, and we do not use the markings to measure urine. This is just for eyeball effect. This is not what we document. We actually have to empty the urine out of here using this little port and measure it in a cup to be accurate. This bag is not anywhere near accurate. If it's tilted, if it's crumpled up on a corner, if it's not hanging straight, it's not accurate. So this bag is going to be attached to a tube that attaches it to the catheter. The catheter itself has two ports at the bottom, one to accept the tube, the other to fill the balloon. This is what keeps the catheter inside the patient. And then you've got the tip of the catheter that has the holes that the urine is going to flow through. I'm actually going to show you this whole system in person. So remember that the catheter and the bag are two separate pieces. Now the reason for that is how long did I say the catheter could remain in place?
30 days.
30 days, and then it has to be changed out. That bag really needs to be changed once a week. So if we have a bag that needs to be changed once a week and a catheter that isn't changed for 30 days, it has to be two separate pieces. Now CNAs do not, again, they do not change that bag unless you've been trained to do so. Much more likely that I'll train you to change the bag than do anything with the catheter because it just literally plugs in together. But there's a huge infection risk here, and we're going to talk about that. Huge infection risk. So the drainage bag can be changed more frequently, usually once a week. CNAs are responsible for cleaning the catheter and the skin around it, emptying the drainage bag and documenting the output, and you can be trained on changing this bag out as well. But please remember that we don't do that normally. So when we're talking about catheters for the test, we never separate these two pieces. We never separate those two pieces. We don't take the catheter out to drain the bag. That's not our job. We're going to clean the catheter and empty the bag. That's our job. That's what they're looking for this skill. If you try to take the catheter out of the patient to clean it, that's a bad day in test world. Okay? They're trying to see, do you know your scope? Do you know what the task is that you need to do?
So you clean it while it's attached to the patient.
Right. We clean it while it's inside the patient.
Okay.
Yep.
It's like peri-care. You're just going around.
Yep. And we're going to go through the whole process, but you're absolutely right. All right. So here's our problem with catheters. Do you guys remember this? Does this look familiar to you? This whole chain of infection thing, right? We have a pathogen. It has a place to live. It's happy in its home, but if it finds a doorway out, now it's a problem. But just being out of the body isn't really much of a threat because pathogens don't live well outside of the body. It needs to catch a ride pretty quick and try to find a new home to get into. But just having a home on the block is not really helpful. It needs to find a doorway or a window that it can get in, a way inside. Once it's inside, if the patient is susceptible, now we can start the whole process again. It has successfully infected another person. This is very relevant to what we are talking about with catheters. Guys, catheters kill about 2,500 people a year. We don't use catheters if we don't absolutely need a catheter. If that urine can come out of the body any other way, we're going to let it come out whatever way it wants to. The only time that we use a catheter is if the urine can't come out by itself because of a tumor or a nerve that won't open up the valve or something like that. Or if you peeing would be inconvenient for something else that we have going on. So if I've got a patient with a huge decubitus ulcer on their coccyx. Remember, that's the tailbone. We talked about that before. So if we have a bed sore on our tailbone or a decubitus ulcer on the coccyx, and our patient is incontinent, right? So urine just comes out. Do you remember me talking about adult urine and how it's acidic and adult urine can eat the skin? Well, if we already have a wound on the backside, open wound, and acid gets in there, that's a bad day for everybody, right? So if we have an incontinent patient and we've got a bed sore on the backside, I don't want that patient just being able to go because it's going to affect that wound. That would be a good reason for a catheter. If you are having surgery, that's a good reason for a catheter, because when we put you to sleep, we put everything to sleep, including that valve. So you're going to pee all over our sterile field and you're not going to have any control over it because you're out for surgery. Right? We put the deepest part of your brain out. So I don't want you peeing on my sterile field, so a catheter is a good idea. If you are giving birth, when you push baby out, you are pushing everything in your body out. It's not selective pushing. If you got something inside, it's coming out. So it is helpful in a lot of cases to have a catheter during delivery because of this reason. Now, if you have an epidural, you absolutely need a catheter because you aren't able to feel anything from here down, and you're going to end up wetting yourself because you're not aware. You can't feel anything. You can't control that valve. So, and you can't get up and go to the bathroom. So when you have an epidural, we use it. So there are medical reasons that we need catheters, but we use them only when we need them and for the shortest time possible. Just being incontinent alone is not a reason for a catheter. Urine's coming out without any help. We're just going to keep them clean. But if we need a catheter, now we got to figure out how to take care of it properly so that we don't leave our patient open to infection risk. And that's where catheter care comes in. Okay? Good? All right, so let's review. This should look somewhat familiar to you, right? We have 2 kidneys in the body. They filter blood. How often do they filter blood?
Always.
Yeah, always, 24 hours a day. They never stop. So those drips are going to fall down tubes called ureters. So drip, 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 drip. Those drips are going to fall into a bag called a bladder, and a little valve at the bottom of the bladder is going to keep that bladder closed. So those drips accumulate until it's full. And then you go to the bathroom, you open the valve, the drips fall out. Nice system. You guys remember this? Okay. This is where a catheter comes in. So when we put a catheter in, this whole system still works. You still have kidneys. They still produce urine. Those urine drips still come down tubes. It still goes into the bladder. All of that's exactly the same. What we've done is we put a catheter in place, and we have this little balloon here to help hold it in place. We're going to talk about the balloon in a minute. But all that catheter is doing is holding open that valve. That's it. That is the entire thing the catheter does, is hold open the valve and allow the urine to fall down the catheter instead of the urethra. That's it. That's all your catheter is doing. Now, you can't put this catheter in with this balloon inflate. Look how big that balloon is compared to that urethra. It's not going to fit. I mean, I could just jam it as hard as I could. It's not going to fit. So when we put the catheter in, that balloon is not blown up. It's deflated. Once we get it in place, then we put some water in there to blow the balloon up. And if you notice, it sits right there at the base of the bladder, and it's a doorstop. That's all that balloon is a doorstop. Now, if I wanted to take that out, that's going to hurt. We know the balloon was small when it went in, so we know it has the capability of being small, right? So what do you think I'd want to do before I try to pull that out? Yeah, make it small again. Absolutely. So we're going to take that water out. It goes back down to the size of the catheter, and then it literally just slides out like a piece of limp spaghetti. Okay. So catheters should not hurt when they go in. They should not hurt when they come out, but they are a little irritating. So let me explain to you why they're irritating. Okay. If we have a catheter in our urethra like this, and there's space around the catheter, if it's not a snug fit, remember I'm holding that valve open. So what do you think is going to happen to urine in the bladder?
It might leak a little onto the tube.
It's going to leak. Yeah, because the tube is holding the valve open, but it's not taking up all the real estate. So that means urine can leak around it. So in that case, our catheter is just marginally effective. So when we put this catheter in, we've got to make sure that we're using one that's big enough to be snug in that opening. Make sense? We don't want any leakage around it. So there's different size catheters. 16 is pretty common, pretty universal. But there's also bigger ones and there's also smaller ones, depending on what we are dealing with. Make sense? We want the catheter that's going to have the snuggest fit. Well, those of you who have pierced ears, have you ever put an earring in that's just a little bit bigger or just, like heavy, like takes up your whole ear hole, and it's irritating. It's aggravating. It's uncomfortable. It doesn't really hurt, but it doesn't belong. So you don't wear those earrings very long. You end up taking them out because they just irritate you, right? But when we have a catheter that's just snug enough to prevent leakage, it's going to push on the urethra and it's going to feel irritating, snug, a little uncomfortable, but not pain, right? It's taking up all that space. Does that make sense? So uncomfortable, that's pretty normal. Pain is not normal. Have you ever had a Charlie horse in your leg? Oh, yeah. How bad do they hurt?
So bad.
Oh, like on a scale of 1 to 10, 22. Yeah, absolutely. All right. That is an involuntary muscle contraction, right? So the muscles absolutely contract. Well, in some people, not a lot, actually like less than 2% of the population, when we put a catheter in their bladder says, hey, you don't belong. And we have an involuntary muscle contraction to try to push it out. It is a Charlie horse of the bladder. If you think that Charlie horse of the leg hurt, try it here. This is, on a scale of 1 to 10, about 102. This is serious pain, right? So if your patient hits call light and says, oh my God, it hurts, ow, 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 don't tell them, oh yeah, that's normal. No, it's not. Uncomfortable, irritating, that's normal. Ow, this hurts, never normal. So uncomfortable, irritating, go tell the nurse, but you can walk there. You can see some other patients on the way. Ow, this hurts. You need to go see the nurse like 3 minutes ago. This is a get your butt to the nurse's station now situation. Does that make sense? What effect do you think pain has on blood pressure? Makes it go up. That's right. And bad pain makes it go up a lot. We do not want this patient's blood pressure to go up. Okay, does that make sense? So if the patient's like, yeah, this is just not very comfortable, let the nurse know. But understand it's pretty normal. That does go away after about 12 hours. So if your patient gets involved in something, if they watch something on Netflix, read a book, do something to kind of distract themselves, that sensation the body gets used to it, right? It does kind of go away after a little bit. Pain does never go away. In fact, it gets worse and worse and worse and worse. We want to prevent that. There are some medications I can give this patient that's having a Charlie horse of their bladder. It's called a bladder spasm. That's the term for it. There are some medications we can give them, but medications have side effects, right? One of the side effects of this medication is in some people, very low percentage, but it's still a risk because I can't tell who it's going to happen to and who it's not. But there are some people that when we give that medication, their bladder goes to sleep. That's a good thing. That's what we want. We want to put the bladder to sleep. But in some people, it doesn't ever wake back up. Ever. Ever. So that's a problem. So we have to weigh the risks and the benefits. Does that make sense? In that patient, I'm going to try my best to figure out another way to handle the pee instead of a catheter.
Maybe a smaller catheter.
Possibly. There's different options that we can explore, but I'm going to work on exploring them. So we have to understand that catheters are not without risk and they're not without consequences, and we're not going to use them just for convenience. That is actually kind of a new concept. Back in the 70s and 80s, if you went to the hospital, you immediately got an IV and a catheter. It was like standard issue, just like gowns and slipper socks. You got a catheter and an IV. Because we didn't want you up roaming the halls. We don't have staff for that. So that changed in the late 80s, early 90s, that this may not be the best option. I mean, we're killing people with infections for catheters they may not have needed. Make sense? Good. The risk here is high. And that's why we have to take this process very, very seriously. All right. So we have the internal system. We have a catheter that's being held in place by this little balloon. It's going to direct the urine into a collection device of some sort, this bag. And as the urine goes into the bag, it's going to fill. Now, usually we're going to empty this bag once a shift. But if you notice that this bag is getting fuller and fuller and fuller, and we still have 4 hours to go of the shift and your urine is here, you need to empty the bag. Don't let it get up into this tube. Does that make sense? So you got to keep your eye on this. Every time we measure it, we're going to write it down on our intake and output sheet. We'll get there in a few minutes. So here is our problem. Do you remember when we were talking about this system with Pericare, I said that we had some white blood cells that hung out in the urethra looking for bad guys that were trying to invade? Got rid of the bad guys before they became a problem, right? You remember that the bladder is the ideal breeding environment. Warm, dark, moist, all-you-can-eat buffet, and open bar. We talked about that too, right? Well, that bag is nothing more than an external bladder. So urine is warm. It's wet. It's not dark, though. There's a reason that those bags are clear and open to light, because that's the only thing that we can affect here. Remember, warm, dark, moist is bad. So if we can at least get rid of the dark, it helps. It doesn't get rid of the issue, but it helps, right? Well, when we are emptying this bag, this port is what we're going to use. So if we open the port, empty the urine, and we let bacteria into that system, when bacteria get into this bag, they're going to start to procreate, because remember, there's an all-you-can-eat buffet and an open bar. Now, anybody ever been to a club, dance, bar, something, right? It's dark for a reason, right? You got all these pretty lights. It's dark for atmosphere, but it's also dark for social reasons. Okay. Now, you can still go to a bar and have the same experiences if the lights were on, right? If you went to a bar and it was bright lit with fluorescent lights, it would feel a little weird, but you could still dance, you could still drink, you could still have conversations, right? But all that's a little easier and a little better when the lights are low. Good? Makes sense? All right, that's this. That is this, right? These bacteria are at a club. The club is the bag. Now, dark would be best, but dark's not going to keep them from eating and drinking and socializing and creating copies of themselves, multiplying. So in this bag, we have everything we need except for dark. So these bacteria are going to start to multiply. They're not going to be great at it, but they're going to get the job done. Now, as this bag starts to fill with bacteria, they need somewhere to go. So they start climbing the tube. This is a long journey, guys. It takes a while to get there, but they start climbing the tube. And as they climb this tube and they make their way through it, eventually they get into the catheter, and now we've blocked out light. Now we have the idea. Everything is perfect. So happy I'm here. And they really start multiplying. So as they're climbing, they do not encounter any of our bodyguards, our bouncers, because they're inside the tube, and our bouncers are outside the tube. They don't even know they exist. So they multiply, 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 multiply. And as they jump out of these holes into the bladder, it's not 1 or 2 bacteria that showed up. It's 1 or 2 trillion. That quick. So when you have a catheter, your patient can go from, I'm fine, there's nothing wrong, to fever, chills, feeling like crap, can't pee, serious issues in hour, right? Because it's this overwhelming invasion all at once, and our body can't fight that off. Now remember, we're not putting catheters in healthy people. We're putting catheters in people that are there for something else. So their immune system, currently busy, currently occupied. You put an overwhelming infection in a patient whose immune system is already busy, that patient has a very high risk of death. Remember, this is an overwhelming infection. Does that make sense? Do you guys see why catheters are so dangerous? So our job here is to keep the catheter clean, the skin around the catheter clean, to know that if we separate these 2 pieces, right here, we separate the catheter from the bag, we need to make sure that we don't let any bacteria in to this. This has to be as close to sterile as we can get it. And we also need to understand that when we empty this bag, we want to make sure that port doesn't touch anything. So do you guys understand? We actually don't. We used to. We used to take an alcohol pad and clean that port before we put it back. And that was the standard for years. But what we found is alcohol is a drying agent. And the material that port is made out of is a type of plastic. And when you dry out plastic, it tends to crack. So it ended up, we made these little micro cracks in the plastic, and that was a place for bacteria to kind of settle in. Warm, dark, moist, hidden was the real problem. So we don't clean the port anymore. We just change the bag usually once a week. Good. Questions? Now, there are some patients, especially home care patients, that may want that bag because they pay for their own supplies. They may want that bag changed every 2 or 3 days if they're at high risk for infection. Or they may not have the money to change that bag every week, and we may have to stretch it for 2. The whole goal is not to let any bacteria in there. Good? Questions? Good. All right, so we need to remember that this is a high-risk environment. Our pathogens Don't need to be in an all-you-can-eat buffet and an open bar unsupervised with the lights off. They will procreate. So there's 3 places that bacteria can enter the system. One is here. This is the one the nurses are worried about. When they put that catheter in, they don't want that tip to touch anything on its way in. It's got to just go where it needs to go and nothing else, because otherwise we're bringing bacteria right into the bladder. So nurses are responsible for this one. You and I are responsible for this one and this one. This is how we change the bag. Remember, I said you're going to have to be trained on that with each patient. This is the one that we're going to learn today, how to empty the bag and not let that port touch anything.
Where does it disconnect at the bag?
It disconnects right here. I'm going to show you. I'm
Oh,
going to pass
okay.
one around, but it disconnects where the catheter and the bag
So
meet.
we would disconnect it to empty it.
No, we
No.
don't ever disconnect this
Oh, okay.
unless
So
we're
you just
told
empty
to.
it at the bedside.
Right.
Okay.
Right. Yep.
Okay.
This we have to have
Okay.
training to work
Okay.
with. This I'm going to train you to work
Okay.
with. Okay, good question. All right, so let me pull out my catheter. Okay, I'm missing my syringe. I'll have to go get my syringe from next door in a minute. Okay. So I'm going to pass this around so you can see, but let's take a look at an entire system here. So this is a catheter. This is a drainage bag. The catheter has a port here that's going to attach to this port, just like that. This is going to be done by the nurse when they put the catheter in. Okay. And it's done in a sterile format. Now that what I just did was not sterile, but it's done in a sterile format. So the nurse has to be scrubbed, sterile gloved. They can't touch anything. They've got to be super, super careful here. Okay. Then the catheter gets put into the patient, and the catheter will be small like this. It gets put into the patient once it's in place, and we know it's in place because we start to see urine. When you strike gold, you're in the right spot.
Where's that balloon part thing?
It's right here. Do you see this thing right here?
Oh, they blow it up.
Well, it's yeah, this is small because we're putting it in the patient, right? You can't have it engaged when it's going in. So this is how it would look when it's going in. Once I get it in place, then through this port, I'm going to inject water, and that's going to blow this balloon up. And that's why I need to get a syringe to show you that. Okay, so these are 2 separate pieces. Now, let me go through this, and then I'm going to show you how that balloon works. Remember that CNAs don't really do that, right? But I want you to understand how this works. So catheter bags have to be hung on the bed, on a non-moving part of the bed. Definitely a non-moving part. Can you imagine you put the head of the bed up and it pulls the catheter out, right? Non-moving part of the bed we're looking for. And it needs to be off the floor because we don't want that port to touch anything, remember? So the bag needs to be off the floor. You want to make sure that the tubing isn't kinked, crimped, folded over, that the urine can move through it. Okay. You also don't want that urine to go back into the patient. So if you lift this bag up above the level of the patient's hips, right? If my patient is laying in bed, their hips are down here. If I lift this bag up, then that urine is going to go run right back into the patient. I don't know about you, but recycled urine, pretty high on my gross meter, right? It's not something I want to sign up for. So we always need to make sure that the bag is lower than the patient's hips. I've seen this in the hospital. Patients walking down the hallway with their IV pole, and they've got the catheter bag hung on the IV pole above their hips. And I'm like, oh, that's just gross. Recycled urine, no fun. We also have to understand that any bacteria that's in that tubing, as the urine flows backward through the tubing, it's going to pick up all that bacteria and take, just like a water slide, right? Those bacteria going, wee, yay, that's awesome, right into the bladder. Horrible, horrible. Yeah, sometimes our patients are going to get confused and they will pull that catheter out. We try not to put catheters in confused patients. Not a good practice because we know they're going to pull them out. We try to satisfy this in any other way we can, and that's why sitters exist, by the way. You're there to distract the patient so they don't be pulling these things out. But some patients will, especially our confused patients. If you notice the patient is tugging on the catheter, making comments, if you kind of assess that they're at risk for this, let the nurse know right away. When a patient pulls this out, that balloon stays inflated. Well, nobody, deflated the balloon. So you've got a balloon this big coming out of a hole this big. You're going to get tissue tearing. There's no way around it. So if a patient pulls a catheter out, you're going to see a little balloon or a little blood. Yeah, some urine, maybe even a little mucus. It's okay. Your patient's fine. They're not going to die. It's okay. But man, do you know what that's going to feel like when they pee? Oh my gosh, it's going to burn like fire. And every time we have injury, we always have swelling. Always have swelling with injuries. So if I have to put another catheter in, remember the tube that I'm working with is it's actually narrower than your finger, right? If that's all the space that I have and I've already got swelling, I'm not going to be able to get a catheter up there. These things are flexible. They're not, they're not very stiff. They're not going to go into a place with swelling. So you need to let me know right away that the patient pull their catheter out, because if I need to put one in, I've only got about a 45-minute window to make it happen. Otherwise, there's going to be too much swelling in the way and I'm not going to be able to do anything. And that can be a really bad day for our patient. Good. If a patient pulls a catheter out, there's a couple things that you need to do. I'm going to come back to that. Hold on. Okay, if a catheter does get pulled out, there's a couple things you need to do. You want to collect both the catheter and the bag, and you're going to put it in a trash bag in the patient's bathroom. Do not just throw it away. Don't take it to soiled linen, soiled utility room. You want to put it in a bag and in the patient's bathroom. Go get the nurse. Hey, patient pulled out his catheter. It's in a bag in the bathroom. You can inspect it. Because as the nurse, if my patient pulls out a catheter and the whole thing is there, it's a good day. I can fix that. I've got options. But if that patient pulls out a catheter and that balloon is broken, that's a very bad day, because I don't know if a piece was left in there. And a piece left in the bladder is a very bad idea, because the body will try to reject it and you'll end up with a lot of complications. The only way for me to know is to actually look at the catheter to see if it's intact. So what I'm going to pass around now is a catheter that the balloon busted on. So you can see what it looks like. You can take a look there. Let me go. Give me just a second. Oh, hey, Marie. Oh, hey, Marie. Hi, Miss Patty. I've been missing your Thursday videos at 3. Are you still having them? Thank you, Marie, for asking. I actually took a couple weeks off because I was working on the new edition of the book. We will be resuming this Thursday. So I will be live this Thursday at 3. I apologize. I had to take a couple weeks off because there was just too much on my plate. But I will be resuming that this Thursday at 3. All right, guys, brief timeout. Just give me about 2 minutes and I'll be right back. a syringe. Okay, so let me show you how this works in a patient. So the nurse would assemble the catheter in the bag. They would lubricate the catheter. They would insert it into the patient, just like this. So now this is sitting in the patient. We know it's in the bladder because we got urine return. Once it's in the patient, the nurse will take this syringe with sterile water and blow up the balloon. And now that balloon just keeps it in the bladder. It's nothing more than a doorstop. You pull hard enough, this is going to come out, right? It's because it's not hard. It's flexible, soft and flexible. So it's not hard. It will come out with enough force. So when we're cleaning, we want to kind of hold the catheter there so we're not tugging it on the inside. We also want to make sure that we're reporting if the patient is tugging on it. Make sense? So this port is what's going to fill and empty the bubble to keep the catheter in or to take it out. On this port, you can actually see the size of the catheter and the amount of fluid in here. This is a 16 French, 5 to 10 mLs of fluid. So I put 5 in there. So I could actually put twice as much. But this port tells you all of that information. So you guys can take a look at how that works.
How would you know how much fluid to say? I wouldn't be doing that, but just for my own curiosity, how would you know how much liquid to put in the balloon?
So this is nursing judgment, and this
Gotcha.
would be done by a nurse. If for some reason, let's say that you and I work at a same-day surgery center, and I'm going to train you because we've been working together a while. You're a smart cookie. I think that I could easily train you to do catheters. All of our patients get catheters. It's a very routine task. So I would take you aside and I would say, okay, listen, we're gonna do this. I'm going to show you how. So I would explain what a catheter is, show you how it works, all of this. I'm going to do one, and then I'm going to watch you do one, and make sure that you don't have any questions. And then once you're on your own, I'm not going to say, hey, Rebecca, right? Yes. I'm not going to say, hey, Rebecca, go give a catheter to room 4. I'm going to tell you, Rebecca, we're going to put a catheter in room 4. It's going to be a 16 French, and you're going to use 5 cc's. There can't be any judgment on your part. It needs to be a routine task on a stable patient. All instructions are given. You are just the hands that are doing the task.
So it's the nurse's judgment.
Nurse's judgment.
Okay.
And that comes with experience.
Right.
Brand new nurses, they get this wrong all the time. And that's okay. You know, they'll, put in too little fluid, or they'll put in too much and the burst, and now we got to take it out and put a new one in. This is part of learning how things are done. So once you do this a couple times, you start to kind of get it, but it's nursing judgment. Now, as bad as that sounds, right? Patients pulling out those catheters, man, that sounds horrible, doesn't it? Yeah, that's not actually the biggest risk. The biggest risk is us pulling the catheters out. We pull out way more catheters than patients do. CNAs pull out a lot of catheters. And the way we do that, here's one. If that catheter tubing is near the floor, your feet will get tangled in it. And when you're trying to untangle your feet, you will pull that catheter out. So where do you think the catheter tubing should be coiled? On the bed. Yeah, not hanging on the floor. You're right. Absolutely. This is a tripping hazard, not just for you, but anybody that comes in that room, including the patient trying to get out of bed. Patients will step on this. If as they get out of bed, it's going to fall to the floor. They'll step on it and pull their catheter out all the time. But the real risk here, that's bad. We don't want to do that. That's bad. But the real risk here is this one. When we get a patient up to walk them, whether we're ambulating them, transferring them out of bed into the wheelchair, if they are up and moving, we need to check to see, do they have a catheter attached to them? Because this is how we pull out most of our catheters. Transferring a patient from bed to wheelchair, catheter still on the bed, and you move the wheelchair, and it pulls the catheter out. Walking a patient may not remember that they have a catheter attached to them. They've got a walker. They take 2 steps away from the bed and plop, there it goes. So we need to understand the risks here. This is us more than the patient. So we've got to be super aware if we're going to move that patient in any way, do they have a catheter? Okay. Good. All right, so a couple different types of catheters. So far, we've talked about indwelling catheters. Remember, I said that this is also called a Foley catheter, right? It has a bubble that we can inflate that's going to keep it in place. It's designed to stay a while. But sometimes we don't need a catheter to stay a while. We just want to put one in real quick, get a urine sample or empty the bladder or whatever, and we're going to take it right out. We're not leaving it. We're not walking away. Just quick in and out. That's what this is. This is 2 names aren't enough for this guy. It's got 3. This is called a straight cath. It's also called an intermittent cath. Well, that makes sense because we're not putting it in and keeping it in. We're putting it in when we need it and taking it out. So intermittently. It's also called a Red Robinson. It's red, and the guy that made its name was Robinson. Okay. So Red Robinson straight cath or intermittent cath is what this guy is. This guy is an indwelling catheter or a Foley catheter. Okay. Good. Then you got this guy. This is a external catheter for men. External catheter for men. It's also called a condom cath or a Texas cath. I don't know why it's called Texas catheter. I have no idea for that. But everything in Texas is big. Yep. But if you turn to page 116, you can see a picture of it there. So that's a condom catheter. It's designed to be put on a patient just like a condom. It's kind of sticky on the inside, so it stays in place. Usually is worn for up to 3 days at a time, and it has a port on the end. This port is just like this port. So our bag is going to attach to it. It's the same port, just on a different apparatus, right? Same port. So our bag attaches to it. This is designed to funnel urine away from the body without anything inside to increase infection risk and irritation, right? Good. The problem with this is that when this goes on the shaft and it's sticky, so it's going to stay in place, the end is going to end like right in here. And then you got this little reservoir area, this little pouch area. That's going to hold urine, which means that urine is going to be held right up against the tip of the penis. What do we know about adult urine? It's acidic, yeah. So when we take this off, we've got to really clean it super, super well because they're going to end up with skin issues if we don't. 3 days of urine right there could potentially cause a problem. Okay, good. So external catheters or condom catheters are used in men. They're a very common appliance that's used. I got it. Very common appliance that's used in primarily incontinent men to help manage the flow of urine. Okay. Now, I put this in the new book. You guys don't have this yet. There is a new way of handling female incontinence similar to this, right? We can't, women, all of our stuff is kind of tucked up and under. So you can't, that's not going to work for us, right? We can't stick something in place and make it work. Well, what they have, this is really, really cool. What they have is a collection device. It's attached to suction. So there's like a little suction machine on the floor with a container, and it has a tube. And then it has this little, it's probably about this long, and it's like cotton lined, like gauze lined on the inside, and it has a plastic sheath to it so it doesn't leak. But you put that right up against the urethra, and it gentle suction pulls the urine away from the skin. So it's working really, really well for our incontinent female patients so they're not laying in urine. So it's a really neat device, and you may see that being used more and more in facilities now. It's actually becoming a little more cost effective.
I think I've seen it on commercials.
Yes, yeah, absolutely. Home use,
too.
yep. They do have it for home use as well. It's really neat. So we are starting to address incontinence in a little bit different way than just peri-care every 2 hours around the clock.
The Red Robinson catheter, that one isn't designed to stay in.
No,
right?
no. In fact, if you let go of it, so I wish I had a trainer here to show you how the catheters work, but if I put this in to a patient, right, and I let go, this is exactly what's going to happen. There's nothing to keep it there. It will literally slide out like a piece of spaghetti. It's not going to stay because there's nothing to kind of keep it in place.
That doesn't, for like the straight catheter, say you put it in place, right? It doesn't leak. Like urine doesn't leak.
Well, again, because we're going to attach it to a bag.
Right, but from the front end.
No, because this and this is exactly the same. Okay, take that bubble away. It's exactly the same. It's actually the same size. Everything is the same.
I think what she's saying, they're going to hold it there for a few minutes, empty the bladder, and then pull it out.
Right.
So they're holding it in.
While it's being used.
The ball will stay in if it's in for a while. The other one is just, they're testing, they're taking the urine, they're pulling it out. They're never leaving it.
Okay.
Can that
Yeah.
be used on male and female?
Oh, absolutely. Yep. So this is probably 30 seconds max.
Okay.
This is 30 days max. Yeah. We used to use these before this was invented. This is what we used to use. Although they wasn't this nice, they weren't flexible like this, like they were metal or glass. Yeah. So, so can you imagine? We've got an incontinent patient, right? We put one of these guys in there, and then somebody has to stand there and hold it for like the next 30 days. That's your job. Just hold this in place. Just hold it.
Did someone actually do that? That's what they
Well,
actually
I mean that I don't. I mean, I'm kind of guessing back in the
Yeah.
1700s,
Oh.
but it would fall out otherwise, right? You can't just kind of stuff it there and leave it. There's nothing to keep it there, so somebody would have to hold it. So that's when the Foley guy came along and said, "Hey, how about if we create something to kind of hold it in place so that you can go do something else?" So that's kind of how this came about. But we started with something like this, although it wasn't this nice. They've come a long way. They were stiff and uncomfortable and probably no fun to put in because they didn't have a closed tip on them. And I can't even imagine. Yeah, definitely. Ouch. So does that make sense? Everybody good? If a catheter comes out, what do you do with it?
Put it in a bag in their trash or in their bathroom, and then get the nurse.
Get the nurse. Very good. Very good. Please don't try to put it back. That will, yeah. I don't know whether that question is still on the state exam, but a couple of months ago, because they change the questions all the time. You know, you're caring for a patient with an indwelling catheter. The catheter was dislodged. What is your first action? A, throw the catheter away. B, hide it so the next shift finds it. C, reinsert the catheter using sterile technique. Or D, put the catheter in a safe place and tell the nurse. Okay. But we want to make sure that you're not trying to reinsert a catheter thinking that that's your role. Okay. Good. So when we are cleaning the catheter, this is where it's inserted. Catheters are always inserted at the top of the peri area. That's where your urethra is. So when the catheter is inserted and you're going to clean it, we don't want to just put the washcloth around it and tug because it's going to pull on the inside. So we want to hold it in place when we wrap the washcloth around and clean away from the body. Remember, we're always cleaning away from the urethra, always. But it's important to make sure that we're holding it in place. Any questions on catheters? All right, I'm going to show you that video in just a minute. Let's go to page 114. And again, this is going to be done on the mannequin because the mannequin in the bed, the mannequin is the one with the catheter. So I'm not going to put you in a bed, you know, with a catheter. So this is, although there's very, very, very little that we're going to do with the mannequin with this skill, other than our opening and closing. That's pretty much it. He'll still talk to her. But our care plan tells us to provide catheter care. Oh, sorry. Let me go to the next one. This is for catheter care. We went over this, right? Okay. Let's go to, here we go. Sorry. Page 114. Okay. So our care plan, you were right. It is 114, Caitlin. Thank you. So the care plan says, empty the resident's urinary drainage bag into a graduate container and measure and record the urinary output.
It's not 114.
It's not 114. I'm sorry, it's 117.
Oh, okay.
Sorry, Caitlin. We'll get it together, I promise. Wait till we have the new book coming today, so we have to redo all these page numbers. I got to redo all these graphics, too. It's going to be all kinds of fun. Okay, so empty the resident's urinary drainage bag into a graduate container, measure, record the urinary output. Remember, in healthcare, we use mLs or cc's. We do not use ounces. You guys remember that? All right, so this is our graduate container. This is what we are going to empty the urine into. This guy. If you look here, you've got ounces. We don't care about that. We are going to use this side with cc's. This is our side. So we're going to empty the urine into here, and then we're going to put this on a flat surface on a barrier, and we are going to read it at eye level. Now, eye level does not mean this. That is not eye level. Upside down is not, because it will affect how you see that level. You actually need to get down and look at it at eye level. Okay, good. So those of you at home, this is a graduate container. You guys see it? We are going to measure to the nearest line. Doesn't matter whether it's up or down. Nobody cares. Whatever it's closest to, the nearest line is what we're going to measure to. So if you look here, you'll see that it's marked in 50. So there's a line for 100, a line for 150, a line for 200, a line for 250. And then in between are little tiny lines. Those are your 25s. So 200, 225, 250 is marked, 275, 300 is marked. So I'll pass this around, let you see it. This is a documentation skill. We need to document the amount of output that we measure. So we are going to use the documentation form in the center of the page. Is urine intake or output? Does urine go into the body or out? I hope so. Okay. So if you look at that form, you're going to see there's a place for intake and there is a place for output. Do not get this wrong. You do not want to record urine under intake. So you've got to really pay attention to this form. Okay.
There's two sides to this.
Yeah, and they both measure the same. The black side is just easier to read.
Right.
Way easier to read. Yeah. They're also more expensive because it's a color dye. So some facilities will only use the clear ones.
Oh, really?
Because they're cheaper to purchase. Yeah, those are just embossed.
Mm-hmm.
That happens during the molding process. The other one has to be actually printed. So they're more expensive. So your facility may use either one. All right, so let's talk about bags. We have different types of bags. We have bedside bags, which is what I passed around here a few minutes ago. They're bigger. They hang on the bed. They hold more urine. We usually empty them once a shift. We do catheter care once a shift too, so they tend to go together. We do catheter care. We empty the bag at the same time. But if our patient is not in bed, if they're out in the community, if they're walking around Winn-Dixie, if they're going to the theme parks, and yes, people with catheters still live normal lives. If they're out in the community, they don't want to be carrying a suitcase full of urine around with them. I mean, that's just, kind of embarrassing. So they would use something more discreet. This is called a leg bag. They both, see how there's a port to attach to the catheter and there's a port to attach to the catheter. They both attach to the catheter. There's no difference here. The difference is in where it's located and how it's emptied. Okay. So bedside bag is going to hang on the bed. We want to make sure that the tubing is not coiled near the floor. The urine bag, the leg bag, is going to attach to the leg. So it's going to go with the patient wherever the patient goes. And there's not a long tubing to worry about being near the floor. This one is going to empty into a container through this port. We don't disconnect this and take it to the toilet to empty it. This one is designed to be emptied at the toilet because this is on a patient that is out and about. This is not on a bed-bound patient. So your patient will go into the bathroom, open this valve at the bottom, and empty the urine into the toilet. So even though they both hold urine and they work very similarly, they're going to have a few differences. This one is based on patients not being mobile. This one is based on patients that are. Okay, good. Questions? Okay, so when we empty the bag, we're going to empty it into that graduate container that you guys just saw. But we don't want to put that container directly on the floor. We want to put a barrier underneath it just in case something spills, we don't get urine on the floor. Okay, so barrier on the floor, cup on the barrier. And then we're going to empty the contents of the bag from that port. When we empty, we don't want that port to touch anything, nothing, not your gloves, not the bed, not the cup, not the chucks, nothing, nothing. When we're done, we're going to close that port and we're going to put it back in its little house. So let me show you how that works. So this is my bag, and this is my port. When I go to empty this, remember it's hanging on the bed. I don't want to lift it above the level of the patient's hips, and I can't disconnect it. So I've got to empty this while it's on the bed, hanging from the bed.
It's still inside the patient.
Still inside the patient, right? Still inside the patient. All of this is still attached to the patient. You don't want to lift this up. I'm going to take this out of its little house. It's got a little pouch here. Excuse me. I'm going to take it out of its little pouch. And this is a T valve. So right now, shouldn't be, hold on. Should never be open. Right now it's closed. If you look through it, it's closed. No urine's going to come out. So what I have to do is push this over to the side to open it. Now it's open and the urine can come out. When I move this T valve, open or close, notice I'm not touching this end of the port. I don't want to do this. Okay. Because if I do that, I'm now contaminating that port, which can allow urine up into the bag. So when you're opening and closing this valve, you want to do it from down here. This is a T valve. So I'm going to open the T valve. I'm going to position it over the cup to empty the bag. It's not Maxwell House. It's not good to the last drop. You don't have to get every last drop out of here, but get as much out as you can. Okay, we want it pretty empty. Once it's empty, I'm going to close that port again and very, very carefully slide it back up into its house without doing something like this. Okay, so I'm very carefully going to slide that right into its house. Okay, pretty easy.
And of course, with this one, you apply gloves.
Absolutely, for both of these skills, because we're touching body fluids. You're touching body fluids. Yeah. So good on that? All right, so we're going to measure the urine in the container, and we want to make sure it's on a barrier when we measure it. It's on a flat surface, and it's at eye level. You don't want to hold the urine up like this, right? So on a barrier, on a flat surface, at eye level, and you're going to round to the nearest line. So this is just below the 450 line, so I'm going to round to the nearest line. That's going to make it 450. So our urine for this particular patient is? Yep, 450 cc's. Those are ounces.
Could you do either?
We don't
one?
use.
Oh, no.
Nope. cc's only. Yep, we don't use ounces in medicine.
Okay.
No. Whenever we're traveling with an open container of urine, you need it covered. Don't just carry a container of urine somewhere. So we're going to use that chucks. Remember, we put the chucks down, put the cup on top of the chucks, empty the container or empty the urine into the container. We're going to wrap that chucks around to take it to the bathroom. Don't just carry an open container. But that gives us a place to put our container to measure it. Now it's on a barrier. We're going to document this. So you want to put under the output section, you want to put the time that you're documenting. You want to put the type of output, which is urine. You want to put the amount, which was 450 cc's, and you want to put your initials. After you document, what do you need to do? Wash your hands. All right, so any questions on those two? I'm going to show you both of these videos back to back. So as soon as the first one is done, we'll start the second one, okay? Once we're done with these two videos, the rest of the class will be practice for you.
Oh, someone sent her a message.
Oh, cool. Oh, hey, Helen. Helen. Hi, Miss Patty. How are you doing? Hope good. It's been a while. I have not heard your beautiful voice. Oh, you're so sweet. But I hope tomorrow will be game show day. How grateful you are. Thank you very much. Actually, thank you, Helen. That's a great comment. Game show will not resume until the first Tuesday of September, so about 2 weeks. But I will be back on my live on Thursday. So make sure you tune in on Thursday. So Thursday at 3. All right, so let me go ahead and get this video going for you. And then you'll have some time to practice in class today. So the first video that we're going to watch is Catheter Care. Sorry, guys. I didn't know. Hi, Miss Jones. My name is Patty. I'm your CNA today. How are you? Good. I need to do catheter care. Is that okay? I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. Okay, Miss Jones, I'm going to gather my supplies. I'll start out with a barrier that provides a clean place to put my supplies. And we're going to get 4 washcloths, a towel, a chucks, a privacy blanket, and now I'll gather my basin and soap. And a set of gloves. All right, Miss Jones, I'll just get some water. I'll be right back. Okay, would you like to check the water temperature and make sure it's okay? It's good? Good. I'll place the washcloths in there to stay warm. And I'm going to cover you with a privacy blanket. This is going to help protect your privacy and keep you warm while we do this skill. And I'm going to pull your sheet down to about your knees. Okay, Miss Jones, I'm going to place this pad underneath you. This is going to help keep your bed dry while we do this skill. First, I'll roll it toward me. And place it on the bed. And then I'll put my gloves on. All right, Miss Jones, can you scoot toward me, please? Thank you. And can you roll onto your left side? 1, 2, 3. Thank you. I'm going to be very careful, making sure that the catheter tubing rolls with the patient and doesn't get pulled on. I'm going to unroll the chucks underneath the patient's hip and have the patient come back onto their back making sure that they don't lay on that catheter tubing. Ms. Jones, can you scoot to the middle of the bed, please? Thank you. Ms. Jones, can you scoot toward me? Thank you, and roll up onto your right side. 1, 2, 3. And now I can unroll the chucks to protect the bed. Come on back, Ms. Jones, and scoot to the middle of the bed. Thank you very much. Okay, now I'm going to start cleaning the catheter. I'm going to roll your gown up inside the blanket. I will be exposing you, but we'll make this as brief as possible. Please let me know if you're uncomfortable. As I roll the gown in the blanket, I want to make sure that I don't grab the catheter, that we don't cause any unnecessary pulling or stress on that catheter. And now we'll cover her thighs with a towel. This exposes only the area that we're working on. I'm going to take the first washcloth and wring it out and apply soap to 4 leaves. 1, 2, 3, 4. Now I'm going to clean your catheter. I'm going to hold the catheter where it exits the body, wrap the washcloth around, and wipe away from the body. Fold that leaf over. I'm going to hold it, wrap the washcloth around, and wipe away from the body. That's 2. We're going to do this 2 more times. Away from the body. 3. And the last one. 4. I'll set this washcloth aside. Whenever we wash, we must rinse. So I'll wring this washcloth out, and we'll use it to rinse that catheter the same way we washed. I'm going to hold it where it exits the body, wrap the washcloth around, and wipe away from the body. We'll do this 4 times. 2, 3, and 4. Set this aside. Now we'll dry the catheter. Now we're going to do peri-care. We'll take a washcloth out of the basin, wring it out really well, and we're going to soap 5 corners. 1, 2, 3, 4, and the back side is 5. Okay, now I'm going to clean the peri area. I'm going to lift the catheter up out of the way with my pinky and hold the labia open while I clean down the center with the first leaf, always going top to bottom, and then we'll remove the washcloth and fold that leaf over. Now I'm going to clean down one side of the labia, top to bottom, fold that leaf over, clean down the other side of the labia, top to bottom, fold that leaf over. I'm going to clean the skin fold between the groin and the leg, fold that leaf over, and clean the other skin fold between the groin and the leg, and then set that washcloth aside. I'm going to take the final washcloth and wring it out really well, and we're going to rinse all of those areas the same way that we washed them. So I'll hold that catheter out of the way and spread the labia open, cleaning down the center, top to bottom. Fold that leaf over, clean down one side of the labia, fold that leaf over, rinse down the other side of the labia, fold that leaf over. We're going to rinse the skin fold, fold that leaf over, and the other skin fold. Set that aside. Now we'll dry gently by patting dry top to bottom and then removing the towel. Ms. Jones, I'm going to cover you back up. I'll unroll that blanket, which will replace the gown over the patient. I'm going to make sure that the catheter and the tubing is coiled on the bed, not near the floor and not where the patient is laying on it, making sure it's not kinked. Ms. Jones, I'll be right back. I need to dispose of your supplies. The towels and washcloth will be placed in dirty linen. The basin is going to be clean the way we clean everything else.
We'll return the basin to the drawer, and on the way we'll pick up the soap. We'll open the drawer with the paper towel and return the basin to its storage area. Now I'll dispose of my paper towels. Okay, Miss Jones, I need to remove the chucks from under you. Can I get you to scoot toward me, please? Thank you. And can I get you to roll up on your left side? 1, 2, 3. Thank you. I'll roll this soiled chucks toward the patient and tuck it under her hip. Come on back, Miss Jones. And scoot back to the middle, making sure the patient is not laying on that catheter tubing. Okay, Miss Jones, can you scoot toward me again, please? Thank you. And roll up on your right side. And I'm going to remove that chucks from the bed. Okay, you can scoot back to the middle. Thank you. This is going to be thrown away. Okay, Miss Jones, let me just look at your catheter one last time. Make sure that the catheter tubing is coiled on the bed, that the catheter is not on the floor. Everything looks good. I'm going to remove the chucks from the table, and we're going to throw this away, and then I'll remove my gloves. We'll throw those away. Okay, Miss Jones, I'll pull your sheet up now. And I'll remove the blanket as I do so, rolling it into a ball. You put this in dirty linen. Okay, Miss Jones, here's your call light. If you should need anything, just let me know. Are you comfortable? Can I get you anything while I'm here, like a magazine? I'm just going to open your curtain and wash my hands. After washing my hands, I'll think about the steps in my skill, make any corrections that need to be made, and then tell the evaluator my skill is done.
All right, any questions on that one? Yeah, we're gonna watch the emptying the drainage bag, and then the rest. Then you'll have a break, and then the rest of the class will be practice.
Actually, I do have a question.
Yeah.
On all of this, you're going to be performing strictly on females. We're never going to have to
For the test.
for the test.
Right. Yes, we will be doing catheter care and peri-care on males.
Right.
So with males, we would use male peri-care,
Right.
which we went over in class on Wednesday. But you just hold the shaft of the penis up, start at the top,
Right.
go down in a circular way around the shaft, clean the scrotum. Whatever we wash, we rinse. Whatever we rinse, we dry. And we're going to clean the catheter the same way. Hold it where it exits the body and clean away.
But for the test,
For the
primarily
test,
it's always
female.
okay.
Yep. Okay, ready for the next one?
Hello, Miss Jones. My name is Patty. I'm your CNA today. How are you? Great. I need to empty your urinary drainage bag. Is that okay? Okay, I'm going to close your curtain, wash my hands, get my supplies, and I'll be right back. For this skill, I'll need a barrier, which I'll place on the floor under the drainage bag. I'm going to need a set of gloves. And I'm going to need a triangular graduate container. I want to inspect the catheter tubing to make sure that it's coiled on the bed and the patient isn't lying on it and it's not kinked, but also that it's not hanging near the floor where somebody might get their feet tangled up in it and trip or accidentally rip the catheter out. This catheter looks like it's in the appropriate position. We'll now remove the port from its protective sleeve on the bag. Sliding the valve to the side will open the port. We can now position this open port over the graduated container and tilt the bag slightly to the side to allow the contents to drain into the graduated container. While doing so, we want to be careful not to allow that port to touch any other surface. Once the urine bag has been emptied, we'll slide the port back to the side to close it and very carefully insert it back into its protective sleeve. We want to make sure that the bag is hanging on a non-movable part of the bed and it's not touching the floor. We can now fold the chucks over the graduate container for safe and secure transport to the patient's bathroom. Once we're at the patient's bathroom, we're going to set the graduate container down on a barrier on a flat surface and position it so that we can read it. We need to be at eye level, and we're going to round to the nearest line, either up or down. You can see that the urine in this container is nearest to the mark of 425, so the amount that we will document is 425 milliliters, or cc's. Once we've measured it on a barrier on a flat surface at eye level, we can now empty the urinary graduate container. We'll throw the barrier away, open up the toilet, and we're going to dump the contents of the graduate container into the toilet. Now we're going to rinse the graduate container. We'll deposit the rinse water into the toilet as well. Now we can clean. After dumping the rinse water into the toilet, we'll set it down, use a paper towel to pick it up, paper towel to dry the outside, a paper towel to dry the inside, and we'll discard this, and then one for the drawer. We're going to place the graduate container in the bottom drawer and close the drawer with a paper towel. Okay, now I'll throw the paper towels away and remove my gloves. We'll throw those away as well. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? A magazine, perhaps? You have your call light there. If you should need anything at all, please feel free to let me know. I'm going to open your curtain, wash my hands, and document my skill. Thank you. After washing my hands, I'll document on the intake and output sheet that the evaluator gives me. I'm going to document the time of output, the type of output, which is urine, the amount of output in cc's, and my initials. After documenting, I'll review the steps of my skill, make any corrections, and then tell the evaluator my skill is done. All right. So Sterlandria says, praying I pass my CNA exam this coming Thursday. We also wish you lots of great luck, and we'll send some good vibes out your way. Let us know how you do, and we'll send you a shout out on Thursday. If you get to us before my live, I'll be happy to give you a shout out. Otherwise, we can give you a shout out the following Thursday to welcome you into healthcare once you pass. Kanisha asks, do we do both skills at the same time, catheter care and peri-care together? Great question. So for the exam, you're going to get a skill set like this, and you have to do the skills in the order that they're listed, but you have to do them all independently. So like they're on 3 different encounters. So this is the care plan right here that would you would have both of these on. You've got perform range of motion of the shoulder, provide catheter care, and measure and record the urinary drainage bag. So you would do your opening, skill 1, closing, your opening, skill 2, closing, and your opening, skill 3, closing. Okay, I hope that helps. Any other questions, guys? Any other questions? That's it for skills. You guys are totally done with skills. Great job. Great job. Wasn't that hard, was it? What do you guys think? It is a lot of information.
And you probably feel a little bit insecure about your skill level because you haven't had a lot of practice. So we're going to open this up for practice. You can certainly take a break if you want to. The rest of the class will be practice. You will have some practice time in class on Wednesday as well. And of course, you have this room available to you for a month after graduation on Mondays and Wednesdays to be able to come in and practice. But you know all of the principles on the back wall. We got those done pretty early. How do we know what to do with each patient? Care plan. We follow the care plan, the whole care plan, Ann? Okay. Every skill starts with an opening. What does every opening start with? A knock. We're going to, how do we know what patient we have? Okay. How do we know that we're working on the right patient? Yeah, right. We want to call them by name and see if they respond. We can ask them, what is your name? That's appropriate too. You can ask them when you come in the room, can I have your name, please? That's okay. But you can also just say, hi, Mrs. Jones, because if she's not Mrs. Jones, she doesn't know what Mrs. Jones is getting. She probably doesn't want any part of it. She's going to let me know she is not Mrs. Jones. What do they need to know about us? Name and title. Very good. And then once we get permission from our patient, once we tell them what we're doing, get permission, we're going to close the, and what's our next action? Wash your hands, because that curtain is right. Very good. Now, after we've washed our hands, we can get our supplies. Can we get our supplies before we wash our hands? Why? Yeah, dirty hands, clean supplies don't go together. So if we're going to go get supplies, we need a place to put them. So what's the first thing we're going to get? Yeah, the barrier, the chuck. So we're going to put that on the table, go get our supplies. Very good. What if we get too many supplies? We realize at the end of the skill, we got stuff we didn't use. What do we do with it? Yeah, that's right. You don't save it for later. You don't store it in the patient's room, and you don't return it. Okay. When we get supplies, what can they not touch? Our uniform. When we're getting supplies, we're going to decide whether we need gloves. So how do we know if we're going to need gloves? If we're going to touch? Okay, very good. Very good. Personal skin, ooey gooey, and non-intact skin. If the answer is yes to any of those, I need. If the answer is maybe to any of those, I need. If the answer is no to all of those, I don't need. Okay. When we're getting supplies, we're going to think about whether, we're going to think about privacy for this patient, right? So we're going to consider privacy. How do I know when I need a privacy blanket? If my patient is uncovered or undressed. When I put a privacy blanket on, what do I want to be careful not to do? Shake it and snap it. Very good. Is the privacy blanket going, am I going to take the sheet all the way off the patient before I put the blanket on? What am I going to do? Okay, put the privacy blanket on first and then pull the sheet down underneath. Very good. Good job. If I'm going to get linens for use, guys, here's a little tip for you for the test when we're trying to remember supplies. Remember, we have to learn our supplies, right? If we're washing a wet body part, or wet, we're washing a small body part, like one hand or one foot. It's like hand and nail care, foot care. You need 2 washcloths, one to wash, one to rinse. That's simple. Everything else for the test takes 4. So that's a really easy way to remember it. Hand care, foot care, 2. Everybody else, 4.
You said 2, but one can wash and one can rinse. But you said we wash, we rinse, we dry. So wouldn't it be 3?
We're going to use a towel to dry.
A towel, not a washcloth.
Not a washcloth, right? Yeah, good question. And you probably could use a washcloth to dry if you're on a small, like a hand. For the foot, it would probably be a little bit harder to dry with a washcloth. But you probably could, and it would be fine for the test if you wanted to do that. But a towel usually is best.
So it'll be 2 washcloths
And a towel. Yep. Very good. Good. What do we want to be careful not to do with our linens? Okay, put them on the floor. Hold them against us. Anything else? Okay, throw them away. You don't want to snap or shake them either. You don't want any floppy corners. You want to control everything. And you don't want to put them directly on the table. We need a barrier there. So there's a lot of things we can't do with linens, right? We have to be careful there. If we have a patient in bed, where do they need to be at all times in that bed? In the middle. If we're going to turn them, then after the turn, they need to be in the. So how do we accomplish that? Scoot toward us and then roll. Which way? Toward us or away? So we are going to remain behind the patients? Behind. Okay, very good. Whatever we wash, whatever we rinse, we don't put soap in the basin because we need water to rinse, right? Oh, thank you. Kanisha says, for the partial bed bath, I see that you did a back rub as well. Those should be done together or only if that's what's listed in the care plan. So great question, Kanisha. Yes, we are only going to do what's on the care plan. For us, it's the care plan, the whole care plan, and
Nothing but the care.
very good. Nothing but the care plan. So if that care plan does not tell us to do a back rub, are we doing one? No. So to answer your question, it's a great question. To answer your question, yes, you're going to do it just like I showed you in the video because that is the testing care plan. But remember that we would only do a back rub if the care plan, instructs us to. Good job. All right. So we are not going to put soap in the basin. When we get the water, we're going to turn the water on and we're going to check it. What should the temperature be? Warm. Okay, who else gets to check it? The patient. What if they complain? Change it. You should also pay attention to whether that water gets cold or soapy as we're doing the skill, and if it does, change it during the skill as well. Why does the patient interpret water temperature different than we do?
Because we're moving around and they're laying still.
Okay, so there's an activity difference. Very good. And there may even be an apparel difference. What else? Very good. So there's some physiological changes that have happened and they've reduced the layer of fat, which is their kind of protector insulator. So they're going to feel water temperature a little bit different than we do. Very good. If we're going to wash a wet body opening, does that change how we use the washcloth? Okay, so we're going to use the leaves method. Very good. And that leaves method is important because it's going to prevent transferring pathogens from one area to another. So we're going to use it if we're going to wash eyes, nose, mouth, rectal area, genitals, wounds, rashes, sores, and incisions. Very good. If we are going to use lotion anywhere, what do we need to do first? Warm it up. And then what do we do after? Wipe it off. All right. So once we've used the basin, it's dirty. We can't put it back dirty. What are we going to do with it? Rinse it. Rinse it, dry it, and store it. That's all we do for the test. We're not going to disinfect. Just rinse, dry, store. But the process I showed you allows for disinfection. So you need to learn the process so that if you do need to disinfect, you've got that process down. Okay. So we're going to dump the water where it normally goes, sink, toilet, wherever, whatever's in your basin would normally go. You're going to rinse it, dump it, and set that down. You cannot touch it while you're disinfecting it. Then we'll use a paper towel to pick it up so we don't have dirty hands touching a clean basin. Paper towel to dry the inside, throw it away. Paper towel to dry the outside, throw it away. And one more for the drawer. Pick up whatever soap, lotion, whatever you need, whatever you used. Put them in the basin before you store it. Makes it a little bit easier. Okay. Yeah.
For the linens part, since they can't go on the floor, dirty linens don't go on the floor.
Right.
If there's blood or poo on it, do we separate that in a bag and then put it into the linen, or?
You're going to follow your facility policy on that. And I can't give you one answer that's going to cover everything. So in your soiled utility room, there's usually something called a hopper. I have no idea why it's got that name. I don't know. But it looks like a really big toilet without a seat on it. It just looks like a big old toilet with no seat. And that's specifically to rinse out linens, to rinse feces off linens or to rinse blood out or something like that. We don't want to do it in the sink, where, we might be setting clean items. So this hopper is used for that. Not every place has their CNAs cleaning the linens before they go into linen. So you kind of have to go by your facility policy. Okay. If the patient's feet hit the floor, we got to talk about their shoes. Are slipper socks enough?
No.
Okay. Why?
They need to go.
Okay. So yeah, you can still slip. They don't protect from sharp objects and pathogens, right? There's pathogens on the floor. They're going to crawl in bed with your patient. That's pretty gross. How do you know your gait belt's tight enough? 4 fingers. What happens if you get it too loose? Okay, yeah, they could slip. We're not going to have a good grip on them. Too tight, they can't breathe. They'll let you know. Trust me, they will let you know. Before we lift a patient, their feet need to be flat on the, yeah. And we want to make sure that they've got shoes and their shoes are well fitting. Once we stand a patient up, we want to give them some time. So what do we want to ask them? Yeah, how do you feel? Are you dizzy? That type of thing. Before we stand them up, though, we need some body mechanics, right? We need to think about how we're going to lift. Do we stand right in front of somebody to lift them up? No. What's a better option? Yeah, so in an oblique angle, very good. 1 foot in front of their feet, 1 foot parallel to their body. That gives us better stability and better maneuverability with our patients. They're less likely to fall. We're less likely to get injured. By the way, where does the gait belt go? Around you or them? Them. Does it go over or under the clothing? Okay, good. I know those sound like very simple things. They're not as simple as you would think. When we go to sit a patient down, what do they need to? Okay, so they need to feel that chair. Do not try to sit the patient down unless they feel that chair. At the end of the skill, when we're all done, what are some things that we have to do before we say my skill is done? Okay, check the care plan again.
Make sure they're comfortable.
Comfortable, yep, comfortable. Call light. Clean environment, I like that. Open the curtain and wash your hands. Very good. And then if we have to chart, that comes last, right? We've done everything else. We charted and then we wash our hands again. Look at how far you've come. Every single thing you just recited was a checkpoint that you got right. Okay? You are well prepared for the test. Well prepared. So let me tell you some ways that you could fail it now that you know the right ways to do things, right? So let's say that you get pulse. If you don't count for 1 full minute, you will fail. Why? Yeah, because we didn't follow the care plan. Very good. Very good. Respirations. If you don't count for 1 full minute, you're going to fail. Why? You didn't follow. Are you starting to see a trend here, right? Range of motion. You do exercises that the care plan doesn't tell you to do. You will fail the test. Why? You didn't follow the care plan, right? Starting to see that? The way that you fail the test is by not following the care plan. This is why that's the very first thing I taught you. So for you guys, you're sitting there thinking, well, that's like a no-brainer. I mean, why does she keep talking about this care plan thing? We got it. Enough. Enough.
You're going to be nervous. You may miss steps.
Right. Very good. Remember, on test day, your brain is going to exit the building. I need this so ingrained in your brain that you don't have to think on testing day. You read it and you do it. And if you do that, everything that I've taught you up here, you've just proven to me is inside you. So this tells you how to do that. The care plan tells you what to do. Everything else we just went over tells you how to do it. Your brain doesn't need to be in the testing center. I've just given you all the keys you need to make it happen. Good? Okay. That's why this program is so successful. That's why you will pass the test, because you really don't have to think about it now. But you will sit there in the waiting room with other people, and those other people will say, what's a care plan? What does that have to do with anything? Because they weren't taught about the care plan. Remember, your yellow book only mentions the care plan on one page. If you look in the index, the care plan is only mentioned once in that yellow book. We know how important it is because I taught you how important it is. But not everybody's going to have that same training. When you get out there and you start working, not everybody you work with is going to have that same training. So make sure that you aren't corrupted by them. Make sure you're the one corrupting them with good habits. Okay? Does that make sense? That's how we're going to keep our patients safe from us, because we're a big risk. All right. So any other questions before I let you free to practice? How did you feel about the class? Did you feel comfortable with it? Okay. Are you happy with the instruction? Is there something that you feel I should have done a little bit more on or a little bit less on?
I've learned a lot.
Good. This is your class. I'm just here to help you. This is your class. I want to make sure that you guys get what you need out of the class. So this isn't about me. It's never been about me. This is about you. And ultimately, if I've done my job right, we'll all make it about the patient. Okay? All right. So for those of you playing along at home, Wednesday we will have graduation, and you probably want to tune in for that because we're going to talk about how to keep our certification once we get it. We'll also talk about how to move out of state if we want to do that, how to get our continuing education, all of those things. We're going to talk about job searching and places to look for jobs that may be a little different than what you have in your mind. Some little known possibilities. We're going to talk about interview techniques, and I'm going to give you a formula to help you answer that one question that everybody dreads during the interview. Tell me a little bit about yourself. I have a formula that you can plug information into that will make you a pro at answering that question. You will look like a superstar. So I'm going to give you that formula in class on Wednesday as well. So for those of you at home, feel free to join us for that because that'll benefit you as well. I will be going live on Thursday at 3 Eastern. So feel free to join us for that as well. So now I'm going to go ahead and log off of YouTube so my class can practice without feeling like they're being watched. Thank you for joining us, guys. Until next time, happy caregiving. Bye.